Okay, and that should now be going. Brilliant. Okay, now it's quite appropriate that we're launching a new digital version of the meetings on YouTube today, because the focus of today's session is on developing and evaluating digital interventions. And we're going to do three main things in the next sort of 45, 50 minutes. First of all, I'm going to kick us off with just a brief overview of some of the projects within Centre for Trials Research, including within population health and social care, that are evaluating digital interventions or using digital methods. And then I'm pleased to say we have our guest speaker today. A warm welcome to Claire Collin, who's going to be here in the Spark building today, who's a PhD student at Université Cité in Paris.
Université Paris Cité.
Okay, right. Sorry, right. I was not right, but not quite. And she's going to be talking about her PhD work, which is really interesting on evaluating digital health interventions and some of the methodologies that are in development. And then thirdly, we'll have plenty of time for discussion and questions for Claire. Before I do my little summary of studies, I'm going to make lots of disclaimers at the start. The first is this is just about really kind of setting the scene. So I'm in no way trying to give an authoritative definition of digital interventions or digital health interventions. Secondly, this isn't a comprehensive overview of studies in CTR. It's a selection of studies that I'm aware of. And it would be great as we go through if people have got other projects that they're undertaking, whether or not you're within CTR. It'd be really great to know more about that, and you can either raise your hand after the at any point, or put your comments in the chat. And some of you, I'll be mentioning your studies today, and I'm sure you'll be able to kind of elaborate as needed. Finally, just to say on that point that if there is anything in this sort of summary that catches your interest, I think I can speak for all my colleagues that any of the people that I named today would be more than happy to talk to you about their work and to discuss it with you. So please do feel free to contact any of the people whose work I mentioned today. Okay. So let me just bring up my slides, and as I say, all of these slides will be available after the meeting. Okay, and can I just check that everyone can see the PowerPoint and that it's displaying as it should be at your end? If someone could just tell me yes.
Okay.
Brilliant. Okay, fantastic. Thank you, Fiona. And then I thought to start with, as I began to prepare for today, well, what is a digital intervention? So we could probably spend many hours looking at what we mean by digital interventions, and I'm sure Claire will sort of touch upon this. But I came across a really interesting article by Weinert and colleagues where they describe a digital public health intervention as addressing at least one essential public health function through digital means, applying a framework for functional classification and stratification categorizes its interaction level with the user. The developmental process of a digital public health intervention includes the user perspective by applying participatory methods to support its effectiveness and implementation, with the goal to achieve a population health impact. And in this study, what they're trying to do, they kind of suggest that actually it's a really quite a complex task of defining digital health interventions. But I really liked their definition, which is this is the one they arrive at, because they draw on existing frameworks to think about, well, what are the functions of digital interventions? How do they interact? What activities do they develop to achieve those functions? And is it prevention? Is it treatment? Is it sort of horizontal interventions across a system, or more kind of interactions between practitioners and patients or participants. And I was really struck also by the way that they place participatory methods at the very heart of developing public health digital interventions. And all of the papers and sources of information have all got, there are links to those in the PowerPoint, so you'll be able to follow these up if you'd like to. Stating, I guess, the obvious, that the development of digital interventions is rapidly evolving, and it's got many dimensions, and it's a bit like going around in circles, I guess, because in the quote above, a digital intervention addresses things through digital means. Well, what do we mean by digital? And I guess it covers a whole range of different kinds of tool, of kind of platform. Oops, sorry, trying to multitask it. We just go back. But also, we know that the use of digital approaches in development and evaluating interventions has really accelerated and taken on new directions as a result of the COVID-19 pandemic. This infographic here is from the World Health Organization's recent guidance on digital interventions. And the reason I've included it here is that for me, it got me thinking about the fact that by digital tools and digital interventions, there are lots of different kind of, I guess, areas of work. So we've got kind of interventions with what they call HIT clients, so participants or patients at point 1 in the top left, interventions for healthcare workers in point 2. But then down the bottom here, it sort of helped me to broaden my thinking in the sense that we use digital approaches for evaluation in lots of different ways. For instance, health systems are using kind of digital approaches, and we may be evaluating them. But also down here at point 4 are systems for actually kind of collecting, managing kind of data. How we actually organize data is rapidly evolving. And I'm going to be talking, and Claire's going to be talking mainly about public health interventions today. But I just wanted to kind of flag, I guess, that within CTR, and I'm sure in other places, there are lots of things that we do digitally. Now, Fiona Lugwidge is with us today, who kind of leads a lot of the work around the use of routine data, which is often kind of digitally based, and how we use that within evaluation. And then also with our trials, we're always developing kind of new ways of actually collecting data, so kind of online platforms to do questionnaires and all manner of different things. So there are lots of different ways, I guess, that digital approaches are informing our work, and lots of ways that we're looking to innovate and to think about how we best manage data. But I'll move on to something I know a little bit more about, which is around some of the current research that we're doing. And it's an area that I'm currently working on with a number of teams. And these were just kind of 4 things, I guess, that have been guiding some of my work, or that seem to be kind of quite prominent when we're thinking more specifically about evaluating digital kind of health and public health interventions. The first is there's a lot of work looking at adapting what were face-to-face interventions for remote delivery, and then looking at how they're actually implemented, both in terms of how they operate, and some of the facilitators and barriers. Secondly, people are interested in the effectiveness of digital interventions, and also whether they might, especially when they're compared with a face-to-face version of the same intervention, do they really achieve their impacts through the same or potentially different mechanisms? Thirdly, there's a big emphasis on understanding inequalities. How can digital interventions reduce inequalities, and what are the risks of increasing, exacerbating inequalities in either in familiar or perhaps new ways through access to technology and so on. And then fourthly, and kind of touching upon the points I made around the work that I know we're doing in CTR, the harnessing of data. So really thinking about what data is in the system, whether it's health, education, social care, and how can we make the most of it. And then Just to say also that within population health and social care as a division and CTR more generally, public involvement and engagement is kind of really embedded in all of the work that we're going to be sort of looking at in the next sort of few slides. So coming back to that quote that I shared at the beginning, there's lots of work going on in the centre, both at kind of study level to think about how we involve the public in development and evaluation of digital interventions. And also we have the fantastic public involvement and engagement hub, which helps to kind of bring together learning and to provide kind of guidance for staff. And again, the link to this page is in the PowerPoint. So before I hand over to Claire, I'll just give you, and for some of you these will be very familiar, I'm sure, some examples of current studies in population health and social care, loosely defined, if you like, around digital interventions. And the first one, the 3P study, is looking at the adaptation of a face-to-face based group-based parenting program, Triple P, and looking at how it's been transferred from face-to-face to remote delivery during the pandemic, and looking at the long-term future of remote delivery and what might need to be in place. We've reviewed the adaptations that were made to enable remote delivery, and we have been looking at some of the further optimizations that might be need to be made for long-term use of remote delivery for that programme in the post-COVID era. We've also been conducting a feasibility study looking at the feasibility of a future RCT, comparing the effectiveness of remote and face-to-face delivery of the programme. And unfortunately, I can't share any of the findings with you today because we're about 2 weeks away from submitting our final report. But just to say that study is really trying to understand what the role of remote delivery within the broader system for parenting interventions might be in the future, but also the perspectives of parents in terms of what is it actually like to be part of a group-based intervention when it's being delivered online. And then there are quite a few other studies, and this is just an indicative selection really, of interventions that are sort of within the sort of young people, parenting, family-based sphere that are exploring remote delivery in some shape or form of what may have traditionally been a face-to-face intervention. So for instance, the Watch Me Play feasibility trial has been looking at an early intervention for caregivers, focusing on parental attunement and attention with their young children, seeking to promote mental health resilience. That's been kind of trying out some remote delivery. The EPAT study is an RCT of a group-based intervention for parents whose children have intellectual disabilities. That's exploring the possibility of remote delivery. And likewise, the Solutions trial, which is evaluating focused brief therapy for 10 to 17-year-olds who are in police custody. And that's also looking at a remote version of what has traditionally been a face-to-face intervention. And there's also a number of grants that are currently under review, looking at kind of evaluations of digital interventions, including parenting programs. And then moving on to something that's a bit more, I guess, around trying to harness data. We've been involved in a project linking in with colleagues in the Decipher Centre and the School Health Research Network to actually digitise information from the 2 yearly Student Health and Wellbeing Survey that the School Health Research Network runs, and actually giving schools their own kind of anonymised, aggregated data to them in a digital form to help promote school health promotion activities. And here's just an example of the kind of one of the pages from the dashboard that we created, which again is about kind of digitising the information, but also looking at how best we can present data to schools to encourage an evidence-based approach. And then finally, just 3 other studies. I think Kim, who leads the first one, VR Melody, is with us. So Kim, you'd be welcome to add in anything during the meeting. And this is a project called VR Melody, which uses VR and AI to address anxiety. The MSK Track study, which has been looking at the feasibility of a digital self-management physiotherapy intervention for individuals with musculoskeletal pain. And then another piece of work that's ongoing, and again, I think Tim Pickles is with us, is doing some really interesting work around digital patient-reported outcome measures, or PROMs. And Tim, feel free to sort of share any more information about that as we go through. So, okay. So that's a bit of a whistle-stop tour. I think what I'm going to do is I'm going to suggest we move straight on to our main talk today from Claire Collin, and then we've got plenty of time then for questions and discussion at the end, and feel free to put anything in the chat as we go through. So I'll let Claire kind of introduce herself, and I won't steal your thunder by telling people what you're going to talk to us about, but your PhD is looking at the sort of methodologies around digital interventions, and I think you're going to be talking about some of the literature review work from your PhD. So thank you for joining us today, and I'll hand over to you.
Yeah, thank you very much. I'm going to present, can you see my slide actually?
I can, yeah.
Okay, perfect.
And can you all hear Claire? Okay.
Yeah, all good.
Perfect. So thank you very much for having me, Jeremy, and for inviting me to present at this division meeting. So Jeremy has a bit introduced myself already. So again, I'm a PhD candidate in Université Paris Cité in France, and I guess my accent speaks for me. And I'm here at Decipher for placement until April under the supervision of Professor Graham Moore. And I met Jeremy in a conference last year in Italy, and that's the first time I got into in contact with him. And then when I arrived, he said it would be an opportunity to present my work. So I'm in the third year of my PhD, and I really work on the methodologies to evaluate digital health intervention to promote health among adolescents and young adults. And I haven't put it on my slide, so I will just say it now. On the evaluation classification that Jeremy presented you at first, I am in this 0.1 client intervention. So a small part of them that is even smaller when you consider that it's only for health promotion and among adolescents and young adults. So it's just a bit of the larger DHIs, but I think it might still be of interest from some of you developing intervention in this field. So first, I will give you a brief overview of the PhD project in general, and then I will discuss some of the results we already have from the systematic review I conducted. And I'm going to go quick on this background because Jeremy has already done much of it. But there has been really an increase in digital health intervention, especially to promote health among adolescents and young adults. And this is because digital technology have penetrated a lot of the adolescent and young adult world. Adolescents use it to socialize, but also to seek for health information. So they are looking to educate themselves about their health on digital means, using digital channels. However, because there's this really increasing number of DHIs, there have been some questions around the evaluation, because we want to have rigorous evaluation of DHIs. And this is especially a question because usually DHIs target a large variety of health determinants. They produce vast amount of process evaluation data. They are usually implemented within a plurality of contexts, even for the same intervention. And all of this within a quickly evolving technological landscape. And therefore, there have been questions around how to best evaluate those interventions. And there are plenty guidance that already exists to evaluate complex intervention, and I've based my work on the one from the MRC. So the MRC guidelines on developing and evaluating complex intervention, which highlight the importance of doing research program in 4 phases. So either developing or identifying interventions, testing its feasibility, evaluating it, and then looking at its implementation. But also highlighting the need for multidimensional evaluation. So not only effectiveness, but also its process, efficiency, and implementation. However, what we see in practice is that most evaluation are limited to RCTs based on a unique primary outcome, usually looking at effectiveness. And although there are RCTs are feasible for DHIs, they might present some difficulties or limitation, and then we kind of starting from there to build our research question. And basically the goal of my PhD was to not do new guidance necessarily at the start, but really to see how we can practically adapt existing methodological guidance for the evaluation of DHIs. So what works with DHIs with what we have already, and what maybe could be improved. And there, my specific focus was on the research program design, the study designs, outcome selection and analysis, and tailored reporting requirements. And to do that, we have we designed a PhD in 3 steps, first doing a systematic review, then conducting a consensus study based on the result from the systematic review to try to draw this kind of recommendation on this practical adaptation of methodological guidance, and then to see whether the recommendation produced during the consensus study could really be applicable to being like new intervention, and whether they help better researchers to design their evaluation programs. So that is a bit of my PhD. As you will see, some of the results we've kind of getting out from the systematic review could be applicable to other non-digital health interventions, so health promotion intervention in general. But I will try to highlight what is really specific to DHIs and what can also be but could also be generalized to other contexts. So I will just focus on the result from my systematic review, and to highlight that I've decided to look at all the research questions we addressed. So I'm not going to the details in each research question, but just to give you an idea on what we're interested in. And then if you want to talk more about the details of it, I would be happy for you to reach out, and we can do that. But basically, our systematic review was guided by 2 main research questions. The first one was around the research program design. And we really, based on the MRC guidance, we really wanted to understand which phases are implemented to assess DHIs, and our researchers really are building and constructing the research program around DHIs, and now they're navigating across the different phases that the MRC is highlighting. And the second one was around the outcomes that are measured to evaluate DHIs and how they use to determine intervention success. And here I'm really talking about success because we didn't want to only look at intervention effectiveness, but all the aspects of an intervention. So feasibility, acceptability, implementation, to define what a successful intervention would be. I will give you the methods we used to conduct this systematic review, the overall methods. So we searched 5 databases for intervention implemented between 2017 and 2023, and the eligibility criteria were really at the intervention level. So we were looking for digital health intervention that were fully digital, so no blended intervention. So there were no face-to-face component, but really fully 100% digital intervention. They could cover any health topic, but they had really to be for promoting health, so primary prevention and health promotion for adolescents and young adults. And we look for all the published articles that were available for the eligible intervention. The intervention had to be evaluated for the evaluation phase of the MRC and at least one other additional phase. And we really gathered everything we could, so preprints, protocols, any kind of publication we could. And we ended up including 26 interventions related to 100 articles. And to give you an overview of the data we extracted, if you would be interested to using them, for each phase of the MRC guidance, so development, feasibility, evaluation, and implementation, we collected everything we could: study design, population, comparators, outcomes, how they were measured, endpoints, and then we looked at the conclusion of the author on their intervention, whether it was a success or a failure according to them, the strengths and limitation of each study, and also the rationale, or when they were described, the rationale for moving to the next phase, saying we've completed development and we now go move to feasibility, for instance. It was kind of a lot of data, so I'm not going to present all of this data, but again, just answer the two research, like give you a bit of insight on what we found on the two research questions I've highlighted at the start. So for the first question, on a research question on study design, on research program design, and I think these results are particularly relevant for DHIs especially, we really looked at the description of the research program duration, the structure of the research program, and the transition mechanism across phases. I'm still finalizing the analysis, so it remains preliminary. So if you have any thoughts or insight for that, I would be most grateful for them. So in terms of research program structure, what we found and what was not really surprising is that you almost have as many structure as you have intervention. So this is quite good. It means that really people adapt the guidance to their own research to answer their own research question and to build their own research program. So like about the among 26 interventions we had, we found 18 different patterns of putting the phase together. However, we found we could distinguish three main patterns of structuring intervention and research program. And they were being either a sequential conducting the phases in a sequential order, using overlapping them or iterating them. And I'm kind of describing these three main patterns we found. The first one here, the first at the top here, is this sequential order. So basically, author developing the intervention, then test their feasibility, and then evaluate them in a really sequential order. You finish one phase, then you move to the other. The second pattern we observe is the iteration of the phase. So doing the phase as many times as you need to complete it properly, or at least you're satisfied with what you found. And this iteration appeared especially at the start of the research program for the development and the feasibility phase, especially. This is quite to be expected in DHIs, because you will like to develop a bit, test, develop again, test again, and iterate these phases until you're happy with the development and feasibility, then move to the evaluation. And the last pattern we found is that the two phases that are often overlapping is the evaluation and implementation phase. And that has been mostly found in under the design of hybrid effectiveness implementation trial that are getting more and more use. So that's a bit what we found in terms of the structure of research programs. In terms of the transition mechanism, we found three main transition mechanism pattern. The first one, although not really used but found, was just automatic transition. So you complete a phase and you move to the next one, whatever the result you get. And it's interesting here, I'm going to give you one example of a feasibility phase that was actually, I want to say, quite negative about the intervention, like the activity was not really good, feasibility was not really good as well, and there was no primary effectiveness result that were positive. But the author still said, we're going to go to the next phase, and they actually conducted the evaluation of the same intervention without making apparent changes to it. Quite not seen often, but we found this transition mechanism. The most common one we found was the transition with a narrative discussion of the findings. So really, the author discussed the positive aspect of the intervention, or what worked very well and what did not work very well. They highlight what they would like to change before going to the next phase, and then they move to the next phase. And interestingly, whereas it's being more and more used and advocated for, We found the use of progression criteria in only one intervention we had to move from a feasibility to the evaluation phase, despite the fact that 23 interventions were evaluated through RCTs. So in RCTs, you could use it's kind of advocated for to use progression criteria to move from the feasibility to the evaluation phase. And despite that, we only found one intervention doing it. My discussion point here are really preliminary again, but it's what we are kind of thinking at the moment. It's really that there is a need for people to acknowledge the guidance a bit more when they're using it or when they're not using one, but just for readers to understand where the researchers are and what they are actually doing. There will be a need to standardize the phase terminology, so authors to be really clear on are they now developing the intervention, are they more testing its feasibility, or actually really being the evaluation phase. There is a need to clarify the iteration processes for sure. We found that there was the purpose of iteration, either it is to refine the content, to refine the delivery modalities, explore persistent uncertainties regarding the intervention is not really clear. So people are iterating in some phases, but we don't really know why they're doing it. And what is the decision-making process driving this need for iteration? And whether they're going to use new methods or new data collection methods to actually generate new data, and how they are changing something in the phase to make new information emerge. They also need to explicit document transition mechanism as well. And we are thinking about would we like to encourage the use of progression criteria beyond feasibility assessment only? And again, do we want to just promote the use of progression criteria more? And finally, there's a question around research feasibility, because we know that conducting this all these phases for a research program is quite long usually. And in the context of DHIs, where you want something to go out quickly, maybe having this overlap of phases could be an option to do things a bit more quickly. So that's a bit about the first research question. And then we have the second research question, which is around the outcomes that are measured to evaluate DHIs and how they're used to design success. And here it's where I've been, this paper is going to be submitted this month, so it's a bit more advanced. And what we did to answer this question is that we described the outcome that were measured in the digital health intervention. We described them in terms of their nature, whether they were effectiveness, process, or outcomes. We look at them in terms of their position, whether primary, secondary, or non-hierarchized outcomes. We also look at them in terms of their result, whether they were statistically significant, not statistically significant, or not tested. And we also looked at whether they were used by the author in relation to intervention success. So usually in the discussion section of papers, author will use, we mention the different outcomes to talk or not to talk about the intervention success. And if the other outcomes were used, we said, okay, author used them to kind of discussed it. And if the outcome were only in the results section of the paper, we were like, they were not discussed by the author in relation to intervention success. Then we looked at the approaches used by author to determine the success of the intervention. And here we found three categorization of intervention. Author describing using either a unique primary outcome with or without additional outcomes, so secondary and non-hierarchized outcomes. Intervention that were evaluated using multiple primary outcomes, and intervention that were evaluated using multiple non-hierarchized outcomes. So we had three categories of intervention we found. And then we looked at the author conclusion regarding intervention success, either they considered it was a successful intervention, an unsuccessful intervention in meeting the objectives, or a non-conclusive intervention, meaning that they had mixed results and they could not really say whether they would recommend using the intervention or not using the intervention. And based on the intervention categorization, we, as researchers, also concluded on the intervention success. So the idea was author might be using things that we don't really know, that they might be using non-published data of their own knowledge of the intervention to conclude. We will only use the intervention categorization, so either the unique primary outcome or the multiple primary outcomes or all the outcomes to conclude on the intervention success. And finally, what we did is to understand a bit how these different methodological approaches could influence the conclusion. We basically did a bit of a simulation. Simulation would be a bit more statistical, but basically we took like 3 interventions from the systematic review that were similar in terms of topics, that were comparable in terms of population and objectives. And we said, okay, we're gonna apply to those interventions 4 different strategy of outcome combination, either using a unique primary outcome, multiple non-outcomes outcome, or weighted approaches, so where you put weight to the outcomes, and to see that whether those different strategies would influence the conclusion we will draw on intervention success. Big task. This is a bit of the result. I'm not going to show go through this figure in details, but basically this figure really put everything I've discussed earlier in terms of classification of outcomes and so on in one place. And this would basically represent the 251 outcome we looked at. And the key finding from that is that we found that DHIs at the moment are evaluated using a wide range of outcomes, process, cost, and effectiveness. And there is really a multidimensional evaluation of DHIs, and this is good because this is what is recommended and actually what is done. So researchers are currently doing that. However, what we found is that conclusions regarding the intervention success are mainly drawn on effectiveness outcome. So we still rely mostly on these effectiveness measures, behavioral determinant, clinical outcome to make our conclusion. We also found that synthesizing outcomes and determining the success appears easier when outcomes are hierarchized, so with primary or multiple primary outcome, yet there is really seldom description on the scientific rationale and process underpinning this prioritization. And finally, we found that interpretative processes by which conclusions are drawn for multiple outcomes and remains underreported. And it's especially true when non-hierarchized outcomes are used. And I can show you here that we disagreed with a lot of we disagreed with author in 50% of the conclusion we drawn, just because we think that author use more than what they say they were going to use to conclude. So they say we're going to use, in the method section, they say we're going to use 4 primary outcomes and that's it. And this is good, but actually they may be using more when they conclude. And as a reader or someone that is coming to look at the paper on your own, you kind of disagree with them because you don't have all the unpublished background knowledge that they do have. This is the simulation I was talking to you about with the 3 intervention. So we kind of did this simulation again. I'm not going to detail this simulation we did, but basically if you look at the intervention on the left, just to give you an idea, when we apply the 4 different strategies, you see that one intervention could either be a success or non-conclusive or even a failure according to the methods you use to combine the outcomes. And what we can get out of this is that when selecting a unique prime outcome assessed at a given time point can really distort the perceived success of an intervention with a risk of being overly positive or overly negative regarding an intervention success. So I'm not saying it's not good. I just said that you can be then saying it's a really good intervention because you changed this unique prime outcomes and all the other outcomes did not change at all, or actually being really negative because you were really good on all the other outcomes except your primary outcome. But is that, how did you choose this outcome? Was it an arbitrary, to which extent, putting all, throwing all away just because the primary outcome is not improved is also a good practice. So we also highlighted this kind of risk of arbitrary choices of the primary outcomes or bonification of study result. And also we don't want to say that the result should dictate the methodology. The methodological choices should always be predefined. We want to highlight that they have a significant impact on the conclusion. And because they are not, the processes are often not well reported, it is really complicated to ensure that the study results are reliable, reproducible, or even interpretable by other people that look at your studies after you. So this is what we found in the systematic review. Here are some of the discussion points around that, around selecting outcomes, prioritizing and combining outcomes, and transparent reporting of methodological decision. So we really promote the development and reporting of theoretical models to justify outcome selection and prioritization. And we would like to investigate the use of core outcome sets for evaluating DHIs, especially for the process and cost-related outcomes. We're also looking at exploring the application of multi-criteria decision analysis and multi-criteria decision making. I don't know if you know these methods in evaluating DHIs, and explore the use of maybe of consensus-driven methods for combining outcomes, and really to look at a more transparent reporting of the methodological decision to allow for reproducibility and comparability of findings. And we're thinking that maybe establishing multidisciplinary and multi-stakeholder steering committee at project outset could be an option to do that, a bit like the trial steering committee, but people that will gather really at the forefront of the project to kind of decide on this methodological aspects. Finally, in one slide, I'm just going to say that those recommendations we've kind of started to develop would be put into a consensus study to a group of experts to kind of see whether they found it's useful for DHIs and how they would like this to be taken forward. So we are looking at doing some nominal groups with experts, with maybe an additional round of online survey. And I'm currently recruiting for that. So if you know anyone that would be interested to participate, have knowledge of this other methodologies for multi-criteria analysis, or are interested in evaluation DHIs, just drop me an email that I've just put here. And thank you for your attention.
Super, thank you. And perfect timing as well. So I'm just going to leave that slide. Well, no, I'm not leaving the slide there because it's perfect.
Yeah,
we can put your email in the chat.
I will do that and stop sharing my screen.
And it'd be great if people are interested in contributing to your study in that way. And I'm sure you'd be more than happy to kind of deal with any questions. But talking of questions, we've got about 10 minutes now. For any questions you'd like to ask Claire, or any reflections, and I'll open the floor up for anyone who'd like to raise a question.
I'm also taking any suggestion for improvement. It can be just be comments and remarks to make my work better as well.
Well, I can't see your hands just yet, so maybe I'll kick off. First of all, by saying how interesting that is, and I think it really made me think both about how we design digital interventions and evaluate them, but actually more generally, I was really interested in what you were saying about almost like how subconsciously, researchers might draw on kind of knowledge or what they've done when coming to their conclusions, but without making that clear. So there were some points there that seemed they had quite broad kind of relevance. And I think my first question was, and this is a kind of an either or question. So you might say to me, well, it's not either or, but especially in your first question, I was thinking, could it be that the guidance we've got is basically okay, but when we come to evaluate digital interventions, we're not always following it? Or is it that actually some of the specificity of the stages with digital interventions mean that the current guidance doesn't quite fit? And the reason I ask that is that I think with face-to-face interventions, it can be quite hard to know when you've got to the end of the feasibility phase and when you move from one phase to the other. So it's a very unfair question because it probably isn't either or, but those two things were sort of battling around in my head. I
think it depends. It's a really interesting question because I think a lot of people are actually wondering about that. And I think if I take the MRC guidance, for instance, because this is kind of really the overarching one, I feel it could apply to, that's my opinion, but it applies to DHIs. But I think it only applies if you take it with enough distance, that it is more of a path toward you want to, like something you want to achieve, like would be aspirational to achieve, but you will not be able to do all what is written in this guidance. And that it's always give you like a kind of a red line. It gives you like the broad thing you need to do or need to consider or not to forget, but there is a role for you to adapt it. And that's where I think DHIs especially are different from the other intervention. Because when I talked about this iteration of development and feasibility, I think in the development and feasibility phase, a lot of the recommendation of the MRC, people in DHIs don't find them really helpful for them because they feel like development is really quick and adaptive and you have to do a lot of refinement and you cannot really follow the the guidance that is for developing intervention as the MRC would tell you to do.
Yeah.
And I feel there, like DHI's researchers have been really clever and have done basically they adapted, they took guidance from other area of research or also like techniques from the private companies and private world as well to develop their intervention differently. But I think still, so there is maybe some gaps in terms of practical guidance, like how to apply. The overarching one that still apply, but might not apply entirely or need to be really adapted a lot to work for DHI. So I think they are here as a nice thing not to forget that we should do, but there's a work to be done around making them practical. And people do it actually.
Yeah.
But either decide to, okay, MRC doesn't apply to me, I will just go on my own way, my own path, or trying to maybe fit too much to the MRC one and get lost into the process because it is a bit hard to apply for DHIs.
So when you're kind of maybe going through quite rapid cycles of intervention testing and refinement, you might think, well, is each one of those a separate feasibility? You know,
exactly. And then maybe that doesn't work, actually. That's why people overlap things and don't make a clear distinction anymore. I think it's not a problem. I just think it's like it needs to be just reported properly and you keep the guidance as, okay, now I've finished this, I want to move to evaluation or something like this. Or not forget some important point on the way.
Okay, so other questions and comments? Christy, go ahead. I think you're on mute, Christy. In fact, you are on mute. I think you are.
Too many buttons to press at the same time. It was just something we were discussing today, and Adam was talking about a study that they did, and it was just people who aren't eligible for the study, but they pretend that they are, and you know, just for any incentives or whatever. And I was just wondering, like for digital, not because I don't know much about it, how do you make sure that you actually getting the information from the right patient? I'm sure there's procedures in place, but I was just curious. How do you know it's not someone else doing any of the...
It is sometimes really hard, to be honest. We'll just take an example of one intervention we did with like sexual and reproductive, like promoting sexual and reproductive health among adolescents and young adults through a digital platform. And basically you had to be at least 16 to be involved, and between 16 and 24. And what we do is like, we usually rely a lot on trust. So just saying, usually what you do is like, you don't tell them that you need this age to participate. You just ask them, what is your month of birth and your year of birth? And then because when usually the people reply to that in a kind of, you can trust that they will kind of like answer this question nicely. And then if they are younger or older, then after that you will have message being, so sorry, you are not in the age range, you cannot participate. And then they could change that the age and do a new thing to try to change. And what we do is like, if you already got this message, we will, and you change your age. We like, you change your age. Are you sure you're in the good age range? Did you make a mistake at first? We try to just do some additional checks before they can really enter the platform. And if they start a new page and do something, usually you try to look whether the information, like, you know, the I don't know, you call that IP, the connection identifier and so on are the same as the connection before. So if they were older or younger, you would get again these additional checks, knowing like you're starting a new application, knowing and so on. But we know, despite that kind of checks we put, that you might not have the right people. Yet we found that if you don't have the right people, if your intervention is really targeted to a specific age range, I guess if you're 35 and you end up in our intervention when you're like between 16 and 25, except you have really a bad intention towards the people there, you will not find the information you're interested in. So we feel like people that will connect just out of interest or not being really patient, they will give up on the app or the intervention really quickly anyway. Except for this, then people with bad intentions that you can imagine have, especially when you're looking at sexual and reproductive health, young people, and so on. And there we do a lot of work on moderation. So each time you have interactive component or thing that could be, when you have any doubt, then we usually have a lot of work of moderation to avoid, like to kind of highlight, like find people that might not be in the right age or something like this. But it's true, I think it's actually a problem. And what people do to avoid that is that they recruit face-to-face and then they do the digital intervention, which I think it's then interesting because in terms of really wide-scale implementation, that doesn't really, like, that adds additional burden because you will not do face-to-face recruitment in real-life settings necessarily. But for the purpose of the trials and demonstrating effectiveness or success of an intervention, they will do that, recruit face-to-face and then move on to the digital part.
And Tim's just put something in the chat there to say there's an emerging literature on, quote, fake participants in research. And in particular, on qualitative online methods, checks are developing, but not necessarily up to speed with the technology. And I was reading this morning that there's some universities where they've had people actually applying to go to universities and using like deep fake technology to kind of actually provide the answers. I'd never get away with it because there's always a cat in the background. Right, Tim and then Kim. Go ahead, Tim.
I wonder if Kim's hand is more relevant to the point that's just being made there.
Okay, sure. Kim, do you want to go first?
Thanks, Tim. I was going to pick up on the fake participants. So we've had a recent experience in one of our studies where we recruited participants to take part in online focus groups, and there was quite strict criteria, but we were invaded by a number of fake participants. Firstly, by bots responding to an online post. So we had an influx of emails that weren't legitimate, but then also people using AI to pretend to be having a particular patient experience. So we've actually just written a commentary which we're submitting, and it's about the fact that, you know, we're not up to speed with the technology that people are potentially using to provide us with online data.
It's fascinating. It's just there's so many dimensions to this, aren't there? That's really interesting. Thank you, Kim. Right, Tim, go ahead.
I'm aware that we haven't got a huge amount of time left, but unsurprisingly intrigued by the outcome measures that we use to test these digital health outcomes. And it does seem surprising that anyone would, well, to me, it would seem surprising that anyone would attempt to test the effectiveness of such an intervention with a single primary outcome. Because in my head, just by the fact that this is years away, whenever I might get around to testing whatever this digital health intervention I may or may not create happens, in my head I would think it would be probably non-inferior kind of intervention, in as much as I imagine it could at best do something similar to normal practice, but could possibly be cheaper. So therefore, I would want to have some kind of clinically relevant outcome and cost as some kind of co-primary. So I just wondered if I'm, well, firstly, just to state, I'm surprised that anyone used a single primary, and then I guess was anyone using like co-primaries of relating to cost or anything like that as the outcomes for these interventions?
So non-use cost outcomes as primary or secondary outcomes. And actually, in the 26 intervention, we found only 4 defined cost outcomes. So cost remain really not enough used outcomes for sure. And in terms of primary outcomes, we are making some hypotheses around that. We believe that the prevailing research environment that has been kind of led by the clinical research and the evidence-based medicine paradigms, when you said that, even the concept guidelines say use a unique primary outcomes. And I think when you want to get funded on a big trial with a lot of money involved, usually the research committee, the funders as well, at least in some countries, I think some places might be different and some funders might be different as well. But for example, in France, if you do any, if you want to get funded by any hospitals-based like funders, you need to have a unique primary outcome in an RCT, whatever you're testing. And of course, I think the research environment is also still pushing to some extent toward this design and these primary outcomes. And I think there is starting to be a move away from that. But I think DHI is, because also they want to show that they are useful intervention, want to fit into this kind of model. And I think it might be also kind of an explanation of why we continue to see that. And this is what is remitted. But then again, when you look at the conclusion, I'm sure the author draw on other things than the primary outcome. But they have to define it just to get maybe the funding and what they need. And then, of course, in the interpretation, they go further. They know that they have to go further than this. But because then it's not described in the methods, we cannot reproduce that. We, as a researcher out external to this, it's really hard for us to interpret what they actually done because it's not written in the methods.
Indeed.
So that's a really interesting discussion, and I'm sorry to draw it to a close, but it's 1 minute to 3 now. I don't know about you. I find this really interesting, really stimulating, and I guess you taught us a lot about all these different aspects of digital interventions, and also for me, lots of questions around how we do the best work that we can, how we present our work to others, how we interact with guidance, and then I suppose how we think about, how kind of traditional ways of working kind of come up against new ways of working and how we can navigate that. So thank you for that, and we'll look forward to seeing the conclusion of your work. I think, Claire, you're around until April, so you're very, very keen and happy to meet with people who might want to talk to you in more detail. So thank you to Claire, and then just to say that our next meeting will be on Thursday, the 20th of March. I've put here 11 till 2. I think I meant 11 till 12. Yes, 11 till 12. And we're just tying it up, but we're hoping we're going to actually be having a session on artificial intelligence and kind of finding out a bit more about some of the work that's going on within the School of Medicine and beyond, about how AI might be used in relation to research, and even a bit more generally, say, in relation to teaching and the kind of systems that we use. So thank you again to Claire. Thank you for all of you for being with us today, and we'll look forward to seeing you next month. Thanks, everyone.
Thank you.
Bye.
Bye.